And good morning, everyone. So we will start now our webinar. Far Eastern University officials, Dr. Rowena Capulong Reyes, Dean of the Institute of Arts and Sciences, Mr. Mark Salvador Isla, Associate Dean, Mr. Frederick Helia, Program Head of Mathematics Department, Dr. Guido David, guest speaker, faculty members, students, guests, ladies and gentlemen, a pleasant morning. I am Nikki Blas, a faculty of Far Eastern University Mathematics Department, and I will be the moderator for today's webinar. It was the same time last year when the first case of then novel coronavirus was recorded in Wuhan, China. A month after, a case of a 38-year-old Chinese woman was recorded locally here in Manila. Months after, the virus has been named coronavirus disease of 2019, or what we call now COVID-19. It has been almost 9 months since a variety of quarantine protocols have been implemented in the entire country, locking us all down in our respective homes. Since then, we have seen a chaotic trend in the data of the infection transmission. In this webinar, we are going to learn how we mathematically look at the data of COVID-19 transmissions and use them to project future cases. These forecasts are essential as the government has been using them to determine the changes to be made in the quarantine protocols being implemented. And to formally open our webinar for today, let us all welcome the Dean of the Institute of Arts and Sciences, our very own Dr. Rowena Capulong Reyes, to give her welcome remarks. Dean Reyes, please.
Hello, can you hear me?
Yes, Mama, we can hear you clearly.
Dr. Guido David, our speaker. Dr. Jose Mamat, the former Dean of the Institute of Arts and Sciences. Mark Isla, Associate Dean of IAS. Frederick Helia, Department Chair, Mathematics Department. Nikki T. Blas, our moderator. Our faculty, Mathematics Department. Special guests, dear students, good morning. How are you? Can you all say hi to each other? How blessed we are that no less than Dr. Guido David, described by FEU's official Facebook account as the man behind many headlines on predicting COVID-19 cases in the Philippines, will share his insights on COVID-19 pandemic modeling. Truthfully, when the pandemic was first reported, we were all hungry for information that could tell us when it would be over. And then we witnessed the predictions given by our very own Professor Helia. Initially, I was happy that he would get it right almost all the time. But then as days progressed to weeks and then months, and then his prediction would indicate that we'll have more cases because of this and that variable, we asked, why is this happening? The article Applications of Predictive Modeling Early in the COVID-19 Pandemic by Poletto et al. Last August said, predictive modeling is valuable when assumptions are related, the variables to be estimated are clearly defined, and researchers or policymakers who use the model outputs have a clear understanding of what can and cannot be achieved by this method. This brought me back to when the Malacanang spokesman used results predicted by the team headed by Dr. David, not for what government could do with it, but as a barometer of whether nanalo ba tayo o hindi, parang basketball lang. I welcome all of you to the Institute of Arts and Sciences virtual activities supporting education. Thank you to everyone who made today happen, our speaker, Chair Helia, Ms. Blas, and Ian Vasco. Muli, welcome.
Thank you very much, Dean Rowena Capulong Reyes, for that message. We are indeed more than excited to listen to an expert in this matter. So without further ado, we will now hear from our guest speaker for our webinar. Okay, let me introduce him to you guys. So, Dr. Guido David is a professor of mathematics and a fellow of the OCTA Research Team in University of the Philippines, Diliman. He finished his PhD in medical engineering and Masters of Science in Mathematics both in Texas A&M University, USA. He also took his professional Masters in Applied Mathematics, Actuarial Science in University of the Philippines, Diliman. His research interests includes biomechanics, mathematical modeling and simulations, computational methods, mathematics of finance, and game theory. With his contributions in these fields, he received the Outstanding Young Scientist Award in 2010, among others. We might be all now familiar with Dr. David as he is one of the faces we oftentimes see in the media because of their team's effort in doing simulations with COVID-19 data. Hence, it is an honor and a privilege to have our speaker for today, Dr. Guido David. Let us give him a round of virtual applause. Good morning, sir.
Good morning. Thank you for the introduction, Nikki, and thank you for the invitation from Dean Rowena Reyes and Director Hela. And also, I'd like to shout out to people I know around here that I see, starting with, of course, Nikki and the Professor Chacha. I know this is in here. Si Professor Pipa Mutok, also a few others. Pinakita ko si Carl, si Genesis John, Sherry Kay. I may have left out a few others. And mga guests, sina Elwin, si Tina, and a few of my students. So I'd like to start with, well, sorry about that. So just like to share my screen. Okay. And I'd just like to go over some of the topics I want to talk about today. I don't know how much time I have, so I filled in a lot of information here, not just about modeling, but about other aspects that may be of interest to people. So I'd just like to give a background. Back in December 2019, some people in Wuhan, capital and largest city in the province of Hubei, reported symptoms caused by a virus. So this was actually 1 year ago. And then on January 30th of 2020, Philippine Department of Health reported the first case of COVID-19 with a 38-year-old female Chinese national. Now, based on what we looked at about the viral strain, we believe, and this is supported by one of my colleagues, Professor Austriaco, that this did not cause a surge in the country. In fact, it was controlled. However, on March 7, the first local transmission of COVID-19 was confirmed. And we actually believe that this was the start of the pandemic when people aboard a cruise ship, which was infected with COVID, returned to the Philippines. So, and this has been the story of the pandemic in the country. Now, since then, the virus has infected more than 400,000 people in the Philippines, more than 50 million people worldwide. And now there are, I believe we've surpassed this 1.3 million deaths worldwide. And the virus responsible for COVID-19 is the SARS-CoV-2. It comes from the family of coronaviruses, and it is closely related to SARS and the MERS virus. And it is for these reasons that some of our other Asian neighbors were more well prepared for the coming of the pandemic, and so they were better. So they were able to prepare for it and manage it better than we did because we were not as prepared. It sort of blindsided us. So I just like to go over a little bit about the basic model for modeling the pandemic. This is called the SIR model. And there are many variations of the SIR model. So that includes the SEIR models and so on, SIS. So it depends on the pandemic that we're modeling. And here, the SIR model is so called because it has three compartments, the SI and the R. S stands for the susceptible. In here, this would be represented by those green people. So they have not contracted the disease yet. The I represents the infected, and those are the ones in red. And you can see that once these infected come into contact with the susceptible, a number of them become infected. Perhaps not 100%, but a certain percentage of them. And we could think of that as the infection rate. And this is similar to the mass action law. So the relationship between the infected and the susceptible is simply a product of the number of susceptibles and the number of infected multiplied by a factor, a parameter beta. Now, after some time, a percentage of the infected will recover or possibly die. And of course, eventually, everyone who is infected will either recover or will either die. So 100% of them eventually move to the recovered state. And these are the gray people in the figure. But the actual rate of recovery is represented by this parameter gamma. And it's only proportional to I, the number of infected. All right. So again, those were the SIR variables. And then we denote by N the total population. And we can assume that the total population is static. Of course, this is a simplifying assumption. It is not accurate, but models are like this. Sometimes we make certain simplifying assumptions. And sometimes we can relax these assumptions depending on what you want to see in your model. So this is fine. Population may be assumed to be static in the short term. And if it's not so, the discrepancies may not be that significant. Okay. And this is the system of differential equations. It's a 3 ODE system, but because we assume that it's a constant population model, it's actually a two variable or two-dimensional ODE system. So the main variables are S and I, and we can even neglect R. If you add all these three, you'll notice that the sum is 0 because the net change in population is 0. But just for completeness sake, since it's an SIR model, we can write all three differential equations. And of course, we will notice that what we know of ds dt, well, it's a differential equation. We can think of it as the slope, the rate of change of the susceptibles with time. And since all the variables are positive, because number of people are positive, then this is a negative slope, which means that the susceptibles are necessarily decreasing, of course. And here the I is it's the sum of this positive beta Si over n, and this difference minus gamma I. Okay, so it may either be increasing or decreasing. And the recovered is a positive gamma I. So it's an increasing, it's a positive slope. So it's an increasing function. We also note the dimensions. In its non-dimensionalized form, S, I, and R would represent the number of people. These are the units is people. T is time. And all these units, S, I, and n are units of people. So the parameter beta has units 1 over time, and the same thing goes for the parameter gamma. So the two parameters I mentioned are the transmission rate, number of infections per unit of time, and the recovery rate, gamma, the number of recoveries per unit of time. The recovery rate is the reciprocal of the recovery time. And then we can combine these into one parameter called the reproduction number R naught. It's beta over gamma. R naught has no units. It's dimensionless because beta and gamma have the same dimensions. And sometimes media will say that the reproduction number is 1%. That is incorrect. It's not a percent. Okay, the reproduction number represents the number of infections made on average by each infected individual. In modeling COVID-19, we can assume that the recovery rate is a fixed number because we can estimate that the recovery time is about 14 days on average. So we can fix gamma to be 1 over 14. So this means that essentially modeling the pandemic requires just one parameter that we have to find out or that we could assume. The reproduction number is well known by epidemiologists and those who use epidemic models, and they use it to assess the infectiousness of a disease. Now, if R naught is greater than 1, the disease will spread, and if R naught is less than 1, the disease will die out. And if R naught is equal to 1, the disease is endemic. So why is that? Well, as we said, the R naught represents the average number of infections of each infected individual over the period of infectivity. So let's say I contracted this disease, and if R naught is 2, that means I will infect 2 other people, but I will eventually recover, and the 2 people will infect 4 other people. Although the 2 people will recover, there is a net increase in the number of infected individuals. Now, if R naught is less than 1, there is a net decrease in the number of infected individuals. Now, of course, R naught is usually greater than 1 for most diseases, because if R naught in its natural state is less than 1, the disease will die out very quickly. It will not spread. So in real life, most diseases will have an R naught greater than 1. But the higher the number, the higher the infectivity or infectiousness of the disease. Studies have shown that the reproduction number of COVID-19 in its natural state is between 2 and 4. This is based on data. So how do we know what the reproduction number is? Well, we simply look at data and we estimate it from data. So in the early stages of the pandemic in the Philippines, this was back in April or even late March, researchers assumed this range of values for the reproduction number and made forecasts based on this parameter value. And this is fine if we don't have the data yet. Although at that time, I was looking at the forecasts and they looked very high. So people were projecting 300,000 cases by May, which I thought was too high, given the circumstances. The transmission rate can be calculated from data on new COVID-19 cases and deaths. And by doing so, we can actually estimate the effective reproduction number. So I mentioned the reproduction number in its natural state. That means without any interventions, if people just go out and do whatever they want to do, no social distancing, no face mask, no lockdowns, then the disease will spread in its natural rate. But because we can apply interventions, then we can essentially control this reproduction number. So we can think of it as a function of time, or it's something, it's a quantity that will depend on time. We can think of it as a time series. So how do we make forecasts? So it's simple. It's actually quite straightforward. All we do is we estimate the transmission rate, sorry, and since we know or we assume the recovery rate, then we can calculate the reproduction number. And we do this based on the data and data on new cases and deaths. And then once we have assumed or estimated the transmission rates, we can now calculate the values of SI and R using the ODE model. We are familiar with ODE models or differential equation models. And all we're doing is, if we know the initial value, what the value it is now, if we can calculate the slope, which I showed you, the ds, dt, etc., then we will know the value at, or we can estimate what the value will be at some point in the future, whatever point we want that to be, whether it's 1 day from now or 1/2 day from now, and then we increment that to get a projection. So as I mentioned, in practice, the reproduction number and transmission rate are affected by many factors, including mobility of people, lockdown, wearing a face mask, physical distancing. All right, so I just like to make a segue and talk about how COVID-19 is transmitted. And generally, especially during the early stages of the pandemic, we decided that COVID-19 is transmitted between people who are in close contact within one another or within 6 feet. Why 6 feet? 6 feet would be more or less about 2 meters. Okay. And we'll explain why that is so. And it's also transmitted through respiratory droplets produced when an infected person coughs, sneezes, breathes, sings, or talks. Okay. Now, other mechanisms of transmission include airborne transmission, which was not very well known initially, but we have known a little bit more about it. And the other is through contact with contaminated surfaces. And this is something that also is not very well known, but generally we advocate hand washing because some of these surfaces may be let's say the face shield that you're wearing, it can accumulate droplets. And if you touch your face shield after you went out, you would want to disinfect or sanitize your hands. And for that matter, you would want to sanitize your face shield. Although personally, I thought it was going a bit too far when establishments required foot baths. So I'm not sure how, droplets from your shoes could get to your faces. But anyway, can't really argue too much about that because more precaution is better than less precaution. Okay, and here is a diagram of an infected person on the left, shedding viral droplets, which consist of large and small droplets. Now, the large droplets tend to be heavier, and they will fall to the ground quickly, usually within 1 to 2 meters. And that's why we advocated social distancing, because if you are within 1 to 2 meters of an infected person, the chances are higher of catching these droplets from the infected person. Now, however, being more than 2 meters from an infected person does not guarantee that you are safe because of the droplets, some smaller droplets may be airborne. And these are the smaller droplets. Of course, they contain less viral load, but they can still be infectious. Okay. So here's a diagram of how two people inside an enclosed space, well, the person on the left being infected and the person on the right being susceptible. Well, here you have an airflow, and you see that the droplets can be all over the room, especially if the windows are closed. Okay, and on the other hand, if the windows are open and you have adequate ventilation and circulation, it is less likely for the person on the right to catch or inhale the droplets because they will tend to disperse. Okay, this is what we know now. So that's why we advocate outdoor activities, or we prefer outdoor activities to indoor activities. Or if we are indoor, we prefer those wherein ventilation is free and we can get outside air. Okay. In fact, we had a notion of this early on, and in fact, we thought that transmissions in jeepneys would not be significant, even early on. In fact, transmissions inside air-conditioned buses would be more significant compared to jeepneys, even though people may be in close contact with jeepneys, but at least there is outside air. And as long as they have the barriers in place, those plastic thingies, we think that those could be sufficient. Okay. So just to look at the mechanism of transmission of COVID-19. So in order to get infected, you need to get exposed to an infectious dose of the virus. So some experts estimate that as few as 1,000 SARS-CoV-2 infectious viral particles are needed to get infected. So what that means is we need to get a sufficient viral load, or a certain number of minimum number of virus things to become infected. If we got only a few of them, it will not be sufficient. In other words, the virus will not be enough to make you sick or infected. Okay. So here's one mechanism for becoming infected, and although this is not yet well established, it's just possibility. So, but we do not know whether a person releases infectious material in feces. But what we do know is that toilet flushing does aerosolize many droplets. So what that means is if you are in a public restroom and someone before you did not flush the toilet and dropped a deuce, and of course you know that for Americans, they refer to number one as urinating and number two as so they call it dropping a deuce. So if someone dropped a deuce there, or basically someone pooped in the toilet, and you flush it, that means it will aerosolize many droplets. That means the stool will release particles in the air, and you may inhale some of them. Of course, when you smell them, you probably inhale some of them, but these particles will be aerosolized when you flush them. So this is not clear if transmission is going to occur, but like I said, it's always better to be safe. And if you can close the lid of the toilet before flushing, of course you should probably do that anyway, but that would be the preferred way. And if there's no lid, well, I don't know, perhaps you could cover your nose or get out of the booth after you flush it. Now let's talk about more direct ways of transmission. So a single cough releases about 3,000 droplets, and the droplets can travel at up to 50 miles per hour. Most droplets are large and fall quickly, but many do stay in the air and can travel across a room in a few seconds. So this can exceed the 2 meters of social distancing. On the other hand, a single sneeze releases about 30,000 droplets, with droplets traveling at up to 200 miles per hour. So sneeze is stronger than the cough. Most droplets are small and travel great distances. If a person is infected, the droplets in a single cough or sneeze may contain as 200 million virus particles. And how many do you need to get infected? Well, you only need 1,000. So if a person coughs or sneezes, those 200 million particles some of them will be in the air, some of them will fall onto surfaces, most fall to the ground. Okay. Generally, we believe that the particles can travel at up to 8 meters, maybe about 24 feet or even longer, slightly longer than 24 feet. So, but if you are face to face or near a person and that person sneezes or coughs straight at you, it is very possible to inhale 1,000 virus particles at once. So just one sneeze or cough and you can become infected already. You probably know that, but this is okay. Now, how about breathing? A single breath releases 50 to 5,000 droplets. Most of these droplets are low velocity and fall to the ground quickly. And if it's nose breathing, there are even fewer droplets released. Now, more importantly, due to the lack of exhalation force with the breath, what that means is when activities require exhalation force, that means virus particles that reside in the lower areas of the lungs or the lower respiratory areas will be expelled if there is sufficient exhalation force. But in breathing, because of the lack of exhalation force, most of the virus particles in the lower areas are not expelled. Particles travel at up to 1 meter for a single for breathing. So unlike sneezing and coughing, which release huge amounts of viral material, respiratory droplets released from breathing only contain low levels of virus. So the approximate value that we use is 20 viral particles per minute from just standard breathing. So with breathing alone, it would take about 50 minutes to infect another person at a close distance or in an enclosed space. So meaning that if you're within 1 to 2 meters of another person and they're breathing, not talking, just breathing, living, then you can get the 1,000 viral particles in about 50 minutes. So roughly about 1 hour. And these are important considerations when you're thinking of going to malls, for example, or going to a restaurant. Then you may want to limit the length of time that you stay in an establishment. Okay. But suppose you're wearing a face mask and this reduces the infection by 80%, then it would now require 250 minutes or about 4 hours of just breathing for you to get these 1,000 particles. Of course, this 80% is hypothetical. We're not quite sure if the actual reduction is 80%. Could be more, it could be less. Okay. How about talking? Talking increases the release at least about twofold or about twice. So we can estimate, let's say 40 virus particles per minute. So if you're near someone who's talking and talking continuously, then it would take at least about 25 minutes, of that person, being around that person to receive the required dose of 1,000 viral particles. It could be actually less because this is an estimate. The talking could release more viral particles. In fact, the range Yes, actually large. It could be between 40 to 200 viral particles per minute. So I'm not saying you're safe if you stay with a person for just 25 minutes. So it would depend on the person. If it's loud talking, soft talking, loud talking would require more exhalation force and would bring more of the particles from the lower respiratory areas out, and again cause more, a higher risk of infection. Now, let's say you're wearing a face mask and it reduces transmission by 50%, which could be possible if someone's talking and they're wearing a face mask, then it will take 50 minutes to get infected. Of course, it could take less again. These are just rough approximations. Now, singing requires more exhalation force. And with singing, the release of respiratory droplets increases up to 10 times. So let's say around 200 viral particles per minute. So if you're in front of someone, let's say you go to a KTV and that person sings one song, 5 minutes, that may be enough for you to get infected. So, but if you're wearing a face mask and it reduces the virus intake by 50%, remember your face masks are not airtight, so some particles may actually go in, especially if they're airborne. So, maybe with 10 minutes you could be infected. So here's an actual case study or an actual event that happened. Here, we have an infected person and had dinner with 9 friends, and the dinner took about 1 to 1.5 hours. Okay, so during the meal, the virus carrier, asymptomatic, well, mainly through breathing, but because of airflow from the restaurant's airflow vents, going from right to left, we see how many of those became infected here. So the person is in table A, and that person is in A1. So 5 out of 10 in table A got infected, mostly those in the draft of the airflow. So you can see that the air is coming from the right and moving to the left. And a lot of those on the B table, on the left table, actually got infected, 3 out of 4, because they're in the upwind direction, meaning the air is going towards them. So that means that the virus particles from the droplets are carrying in the air and being transmitted to them. However, it's curious that some of those in table C, a couple of them actually got infected as well, whereas none from tables E and F got infected. So this is important when you're thinking of course, you don't know where a person, if there's a person who's asymptomatic or infected, and so it would be a challenge to seat yourself. But generally, if you are seating, it's probably better to seat close to where the source of the air, so at least the air will not be coming to you, but coming from you. It's just just something to consider. Of course, it's better if you're sitting outdoors or near an open window. This would be fine. Or if there's an electric fan, you'd be near an electric fan. So based on studies, we know that all infection events were indoors. Well, most infection events were indoors with people closely spaced, lots of talking, singing, or yelling. Main sources for infection are home, workplace, public transportation, social gatherings, restaurants, and yeah. So this accounts for about 90% of transmission events. In contrast, outbreaks spread from shopping appear to be responsible for a smaller percentage of trace infections. Why is that? Because, well, malls tend to be larger. Of course, I mean, that's assuming that they're social distancing. They tend to be larger. It's almost like you're being outdoors. Air can be circulated. That means, even if there was someone walking around having symptoms or, being asymptomatic, it's not likely that they will disperse their droplets in just one area. It will most likely be dispersed all over. Okay. Also, as only a single outbreak event has been reported from an outdoor environment. So less than 0.3% of trace infections. Okay. And just a quick guide on riding buses and trains. Of course, we should avoid touching surfaces, should practice social distancing, hand hygiene, wear a face mask, face shield, avoid touching your eyes, nose, and mouth with unwashed hands, cover your coughs and sneezes with a tissue or use the inside of your elbow if you don't have tissue. Throw used tissues in the trash and wash your hands immediately with soap and water as soon as you can or with a disinfectant. So I just want to cover a bit, go over a bit on COVID-19 status in the Philippines. Here we have a heat map, they call it. So we can see that these are the number of active cases all over the Philippines. And right now, the epicenter is actually here, of course, in Metro Manila. And that includes Cavite, Laguna, and Rizal. So more than 1,000 active cases. And also in Davao City, the red area on the bottom part. If you're not well versed in geography, then I'm sure all of you are. And then the orange portions are those with at least 500 active cases. And we see that Quezon, Batangas, Bulacan, and Pampanga are in here. And that also includes Benguet, Baguio City, Negros Occidental, Cebu, and this part, I think this is Misamis Oriental. So my geography is not quite up to speed either. On the other hand, those with green and even the bluish green areas represent very low caseloads, especially here. What's that? I think this is Abra, and some parts. This one, Antique, okay, and Southern Leyte. All right, and this is just a quick comparison. This is from WHO. This is only up to October 12th, and it compares the epidemic curves of a few countries in Asia. And we see that, okay, we are overwhelmingly, well, on the right side, a lot of the cases were occurring in the Philippines. Yay. So, of course, it's been on a downward trend since, and that's what we've been reporting or what we've been seeing. But we are followed by, I believe, Japan. Indonesia is not in this chart, in case you're wondering. So when we track the COVID in the Philippines, what do we look at? Well, we look at several indicators. Of course, we look at new cases per day based on case reports and test reports. Then we look at the reproduction number. I mean, this is something we calculate. Then we look at the positivity rate, which is the percentage of people who are tested who are positive. The attack rate, which is the number of cases, but normalized to population. Also look at hospital occupancy and case fatality rate. So here, we look at the number of active cases. Although this is from our model, this is the theoretical number. It approximates the actual value, because the way the Department of Health did the recoveries was, well, they did en masse recoveries. Once they figured that a lot of people were not recovering because they were not reporting them, so they just said, okay, well, after 14 days, let's mark them recovered. So their figure looks more like a step function, which I don't like. So I believe this approximates the number of active cases. So it should be roughly around 25,000 now. And we can see that the active cases has in fact gone down. And this is what we refer to when we're saying that the curve is flattening, or at least what I did. Because when we talk about flattening the curve, there's a lot of confusion, because in the first place, it depends on what you consider the curve. So what is the curve that we're flattening in the first place? And many regard flattening the curve as flattening the total number of, well, the number of cases, or that means the number of cases going to zero, number of new cases. If that's the case, well, that's actually like ending the pandemic when you don't have any more cases. So one way to think of flattening the curve is flattening the active cases, or at least getting it on a downward trend. So yeah, so we have been on the downward trend since the peak, which occurred sometime late August. Okay, and another definition of flattening the curve is changing or the trajectory of your epicurve so that it becomes flatter compared to what it would have been. So here, this is a diagram of, well, the white bars are represent the total number of cases in the Philippines. And here we calculated the effective reproduction number for periods of the pandemic. Although the reproduction number can be calculated almost daily, but here we calculated it over a period. So for example, from April 1 to June 1, during ECQ and MECQ, the effective reproduction number was around 2.03. From June 1 to August 4, when we declared MECQ, the effective reproduction number was 1.25. Now from August 4, the reproduction number was about 0.78. I think this is up to October only. But if we look at a hypothetical, if the reproduction number was not changed, or was what its average value at that time was 1.32, then we would follow the trajectory of this yellow line. So this is a theoretical line, but let's suppose that this was what we were supposed to experience, but because of interventions, for example, like MECQ, we actually change the trajectory and instead get the white bars. And essentially we have, what we did was essentially flattening the curve in the other definition that I was talking about. So if we follow this, by October, we would have already been at 400,000 cases, but instead we were at about 300,000. Of course, now we're at 400,000, but if we follow this trajectory, it could have been at about 600,000 cases by now. Okay. We also look at mobility. So based on apps that collect information on mobility, and the mobility is measured in terms of percentage difference from the normal. And we can see that during the start of the ECQ in March, the mobility decreased by 80%. Then when we moved back to GCQ, it was at about 70%, minus 70%. And then when we implemented MECQ, it was again reduced to almost 80%. And then here we see some effects in mobility due to the typhoons later. I mean, towards the right part of this graph, there were changes in mobility due to the typhoons. Okay. And as I mentioned, another indicator that we look at is the positivity rate. And again, this is the percentage of tests, PCR tests that turn out positive. And we see that in Metro Manila, the positivity rate was as high as 19% back during the in late July, and indicating the surge. Of course, the positivity rate is affected by the state of the pandemic, but also it's a function of our testing capacity. Right now, our testing has actually not been increasing. In fact, it's almost flat, or in fact, it's even decreasing. But because of the decrease in new cases, the positivity rate has gone down to less than 5%, which is great news for us because that is the World Health Organization standard. It should be below 5%. What that also means is if your positivity rate is high, it means you're not capturing most of the COVID cases who are out there. But if your positivity rate is low, that indicates that you're actually capturing most of the COVID cases out there. Okay. And again, we also look at hospital occupancy, which is percentage of beds in hospitals which are occupied. And this is our most recent data back in November 27. We see that in Metro Manila, only NCR has greater than the 70% occupancy, which is the threshold set by the Department of Health. And some places have very low hospital occupancy, and this is a pleasant surprise because back in August, more than half of the LGs had were red here. So more than half had 70% or more hospital occupancy. But now we see that places such as Caloocan, Mandaluyong, Nabotas, Malabon, they have low occupancy, indicating that, well, their hospitals are basically not full, or in fact, not even full, but almost empty. I mean, their COVID beds are almost empty. And I just want to finish up with some forecasts. I'm not going to write down all the projections that we made, but this was early on. Back in April 8th, there were 3,660 COVID cases in the country. And there were some projections which were quite high. And at that time, I thought, well, maybe I could put out some projections which were more in line with my appetite, because I couldn't look at the projections for, hundreds of thousands or millions of cases at that time. So what we did was to calculate the reproduction number at that time. And we projected that by May 8, after 1 month, there would be 12,200 cases and 980 deaths. And by June 8, after 2 months, there would be 29,000 cases and 2,600 deaths. So this was one of our first projections. And we showed this to the national government, and they actually liked the projections. And in fact, on May 8th, there were, the actual number was 12,969 cases. Wait, I'm not sure if it's 980 deaths, but okay. And on June 8th, there were actually 25,137 cases. So it was actually lower than the projection by a little bit, okay? So this was from the actual graph that was in the report. And some of our projections, this was the end of June projections, wherein we were matched up with spokesperson Harry Roque, and syempre, talo na naman yung UP. So we projected 40,000, actual was 37,000. End of July, we projected 85,000. Actual was around 92,000. Yeah, so we were usually within 10%. End of August, we hit it was the median of our projections. We projected 210 to 230. Actual was 220. End of September and end of October, it actually hit the lower end of our projections. Now, the projections are not predictions. We're not predicting stock markets or anything. These are just mainly saying what it's saying is roughly this is the trend now, and we're seeing this trend. If this trend continues, this is where we will be. It's something similar to like a interest rate projection. So anyway, important thing is it's okay to be wrong with your projections. You just don't want to be too far wrong. But if if the numbers are actually lower than your projections, that's actually good for the country, of course, and that's what we want. But we're just basing it on science. There's no sentiment here, and this is what it says. So end of November projections, actual was actually close to the median of our projection, the mean. And end of December projections, let's see, because right now we're seeing an uptick. It's not a big uptick, but there is a definite increase that we're seeing right now in Metro Manila. So I think that's, I will end my talk there. So thank you for giving me the time, and I'll turn this over back to Nikki, and maybe she can facilitate questions if there are any.
Yeah. Thank you so much, Dr. David, for that very insightful discussion. So now, okay, I'm quite sure that our viewers have lots of questions in mind now. So with that, we are going to open the floor for questions and clarifications to our guest speaker. So you may key them in the meeting chat box or leave a comment in our Facebook Live video. So here are some initial questions. What do you think are interventions that we can suggest or have been already suggested to the government to continuously flatten the curve despite this coming holiday season?
Yes, I have been advocating for mass testing even early on, but this is not something that has been done, I think, because of limited resources. Although we heard this firsthand from the local government, and we also saw this in the news. There was an incident, I think it was last week or 2 weeks ago, wherein the new Speaker of the House, the Speaker Lord Alan Velasco, ordered the employees of the House of Representatives to undergo testing. So this was like a mass testing. And out of 2,000 members of the House of Representatives, 5% or about almost 100, I think 98, were positive. So this is actually scary. I mean, that's a positivity rate, but of 5%, but it's for people who are not exhibiting symptoms. So this shows that mass testing, even if we're using not PCR, but let's say antigen tests, could be an effective way for us to measure or to estimate the state of the pandemic, especially in certain regions. But anyway, the national government won't, or the local government won't, have not gone for that. Some other interventions, well, actually we're on a downward trend, so that means that our interventions are working. But as you know, the decision right now of the government is to open up malls, have more people eating outside, going shopping. So I will just call out, I mean, make a personal, well, message to people to, just be conscious and, even if it's allowed, even if you're allowed to go out, the virus is still here. So it's better for us to, you know, mind our, I mean, to be mindful of best practices and to avoid going to crowded places, avoid going to the congested areas and enclosed spaces. Yeah.
Thank you so much, sir. Another question would be, can we determine how probable is it that we contract the disease from, for let's say example, food deliveries or from your shopping items, Lazada and Shopee?
I would say, based on what I presented about, viral particles, uh, the probability is small for package deliveries. And also, there is no known transmission of the disease in food. For example, if your food is got some droplets and you ate it, it does not seem to be a pathway for contracting the disease because the food will go inside your stomach and the virus will be destroyed there. The path for virus is to go to your respiratory tract. So the risk will be minimal. But if you're face to face with a Lazada person and you're not wearing a mask, of course, the risk will be more significant, especially if you're talking to that person. So, but just getting packages, especially if as a general precaution, you disinfect packages. Um,
Yes.
the risk should be minimal. In fact, I've not heard of. I mean, there might be isolated cases where infections occurred, between Shopee riders and a person, but I think these are just few, and this indicates that the risk is minimal.
Okay. Thank you, sir. Another question would be, how do you factor in testing rate? Isn't the reliability of your key indicators based on how much we are testing and monitoring the spread of the disease? How much of the reproduction of the new case is due to the slowdown of the testing when Red Cross stopped testing?
Yes, actually, we saw that when Red Cross stopped testing, and Philippine Red Cross accounted for 38% of testing in Metro Manila. So we measured that. So what happened was there was a decrease in number of cases at that time. And we even mentioned that in our media reports that the decrease is partially due to it's an artificial decrease due to the absence of testing of Philippine Red Cross. And when Philippine Red Cross resumed testing, the numbers went up and it accounted for the backlog of testing. So that has already been accounted for in the model. So, and that has already passed. So right now the uptick is not due to that anymore, but it was factored in. So yes, that's a good question. And we did factor it in. We did see the decrease, the dip in cases due to Philippine Red Cross, and then the increase because Philippine Red Cross resumed, but they were, the general trend was still a downward trend. So it did not really affect the general trend of the pandemic.
And in connection to that, sir, so how do we know if you are testing enough? If you are testing enough?
Yeah. Per World Health Organization standards, we're testing enough if we're getting 5% positivity rate or less. So, but the positivity rate is not the same in all areas. So in Metro Manila, our positivity rate right now is 4%. In some provinces like Quezon, it's 18%. So they're not testing enough. In many places in Mindanao, positivity rate is quite high, like 20% or above. Not Davao. Davao has a 9% positivity rate. So so it varies, but I think the positivity rate tends to be higher in the Mindanao region and in Quezon. In Ilocos and Cagayan, oh, well, not Cagayan. Cagayan right now has an 8% positivity rate, which is a bit high, but it's okay. In Ilocos region, positivity rate has always been great. It's always been around 2 to 3%. So for I know for sure that in the Ilocos region, testing is sufficient because their positivity rates have always been low, even though right now there is a surge going on in Lawag, and we're seeing that as well in Ilocos Norte.
Actually, I'm currently in Lawag and
Oh,
undergoing the
sorry.
mandatory quarantine.
Okay. Mandatory quarantine, bakit?
I came from Manila and then I need to undergo an 14-day
14 days.
hotel
Okay.
quarantine before they release me. But there has been a spike of positive cases recently here in
Okay.
Lawag.
I hope you didn't bring it there. Joke.
I hope so. Just waiting for my swab result. Okay, so I think if our viewers have, yes, do we have forecast per provinces? Other question. Forecast per provinces. Because most of the slides earlier was focused on NCR.
Yeah. So what was the question about other? I did show the other provinces. Otherwise, we would be here the whole day because we actually, I mean, we don't look at every province, and in fact, right now we look at not just provinces but also in the city level. We haven't been doing that for a while, but we started doing that and looking at attack rates, but it became too tedious. But like I mentioned, we are able to track down which cities are having the surge based on the attack rate. And we, in fact, saw this a few weeks ago when there was a surge in Benguet. It was not only in Baguio City, but also in Itogon and La Trinidad, and even in Tuba, Benguet. Now, I think there's a spike in Mangkayan in Benguet. So we're seeing that. We're also seeing right now some a spike in Isabela. A few weeks ago, we saw something in Tarlac. I think last week or 2 weeks ago, but now it's been managed. So in general, what we notice with provinces is that provinces are able to manage the pandemic very well. So even when a surge happens, they're able to control it and bring it down back to safe levels. But this does not happen in major metropolitan areas. Of course, Metro Manila, that's why I talk about it, because it has been struggling to manage the pandemic. That also includes Davao City, some major areas such as Bacolod, Iloilo, Baguio City, Calabarzon, parts of Central Luzon. Although Cebu is the model case of a province or a city which had a major outbreak but has been able to control the pandemic, and now they're managing the pandemic well. Their positivity rate is, I think, less than 5%. And even though a surge a spike occurred 2 weeks ago, they managed it and they brought it down. So it's a case study of how you manage the pandemic.
Thank you so much again, Dr. Guido David, for answering those questions. But if you still have questions, we might not be able to address them due to lack of time, but we will be forwarding them to Dr. Guido, and then we will be sending you his response in due time. So thank you very much for your understanding. And just some few announcements. Please do follow our Facebook account, Far Eastern University Mathematics Department. Okay. And can I share my screen also, sir?
Okay, sure. Sorry, let me stop.
Far Eastern University awards this Certificate of Appreciation to Frederico Guido P. David, PhD, for his valuable contribution as guest speaker during the Predictive Analytics webinar series on COVID-19 pandemic modeling, given this 4th day of December 2020 at Far Eastern University, Manila. Signed, Frederic S. Helia, Chair, Department of Mathematics. Signed, Rowena Capulong Reyes, PhD, Dean, Institute of Arts and Sciences.
Thank you. Thank you so much. Thank you, everyone.
And at this point in time, we would like to call our program head in the Department of Mathematics, Mr. Frederic S. Helia, to give us his closing remarks. Sir Helia.
Yes, good morning. Thanks to our resource speaker, Dr. Guido David, for an enlightening presentation on forecasting the pandemic COVID-19, from estimating the transmission rate and reproduction number based on data on new cases and deaths, and calculating the values of SIR using ODE model. You have provided us a valuable knowledge on how to do a predictive modeling on pandemic cases such as the COVID-19 cases. Aside from the predictive modeling, you have also shared other valuable information relating to COVID-19 in the Philippines. We really appreciate for having you here in our event. I would like also to thank the Dean, Dr. Rowena Capulno Reyes, and Associate Dean, Mark Salvador Isla, for co-founding and envisioning AYA's virtual activities supporting education, or the VACE, as the primary supplemental tool in uplifting the knowledge and skills to everyone at AYAS. Hence, we have this kind of event. I would like also to thank Ms. Nikki Blas as the moderator of this event, and Mr. Genesis John Borja for leading this webinar. From conducting distinguished resource speaker like Dr. David to execution. Without him, this event is not possible to happen. I'm also extending my thanks to Mr. Christian Ivasco for the help in streaming this event live on Facebook, and also to Mr. Richmond Riaden Lim for the technical concerns. And of course, I am thanking each of the participants for joining us in this webinar. I hope you find this webinar helpful in predictive modeling. Maraming salamat po sa inyo lahat.
Thank you very much, Sir Helia, for that message. So before we end this seminar, we would like to extend our sincerest gratitude to the following people who helped in making this webinar possible. Frederick, Dr. Guido David, Dr. Rowena Capulong Reyes, Mr. Mark Salvador Isla, Mr. Frederick Helia, Mr. Richmond Lim, Mr. Eugene Ebasco, Dr. Richard Lemense, Mr. Carl Joseph Hamasin, Mr. Genesis Borja, and Mr. Tomas Herald Vergara. We would like also to invite all of you again for our next webinar on December 11, where we will be talking about 7 plus N ways physics has changed the world. And finally, can you please do accomplish the survey form through the link now visible on your screen. So let me just, this one. And also I sent the link wherein you can request for the e-certificates. Okay. And at this juncture, I kindly ask you to open your cameras for some photo ops. And so smile. And smile. And so I think I got everyone in for the photo. So that concludes our webinar for today. And again, thank you again very much. Thank you very much for joining us, and have a great day and keep safe, everyone.